Welcome back to the channel, everybody. Today's case deals with a re-DMEK for a 28-year-old male with congenital glaucoma, which was operated on when he was a young lad with trabeculotomy, and he did very well up until his 20s when he required an AMET valve in this eye. After the AMET valve, there was a problem with endothelial touch and the valve was explanted, and then pressure rose again, so he needed a new implant, and he currently has a Paul Glaucoma implant in the infranasal quadrant, which is positioned at the top left of the screen. And because of the endothelial decompensation, we did a DMEK for him 6 months ago, and then he developed a rapidly evolving cataract, which we had to operate on fairly quickly, about 3 weeks after the initial DMEK. And because of that, that initial DMEK failed. And now we're back in the operating theater with him under general anesthesia doing a re-DMEK. And we're doing a re-strip here under air. And you can appreciate the pretty advanced corneal haze. One of the anatomical particularities of the case is the reduced scleral rigidity, which makes this eye behave very differently from any of the usual eyes we have. So congenital glaucoma cases have a reduced scleral rigidity, which makes the AC want to collapse upon itself, even though the patient is under IV mannitol. He has an IOL instead of his natural lens, and he's highly myopic with a very big white and a very big AC. But still, you would expect his AC to be deep during the stripping and during the graft implantation, but no, it always wants to collapse. So we've injected the graft, which is 9 millimeters, and you can see that it doesn't come close to occupying the whole of the AC white to white, limbus to limbus, and that's because his white to white is about 13 millimeters or close to 14. So now we're using the AC maintainer to be able to have some depth to position the graft, but then we remove it to be able to start unfolding it. So the graft is in a bouquet configuration right now, pinned against the temporal angle. We're deepening the chamber a bit. It doesn't want to deepen too much, so we're not wasting time on overinflating the chamber. And we appreciate that the graft was upside down. So now we're flipping it. It wants to follow us to the paracentesis. We move it out of the way, and then we're constantly trying to deepen the chamber as little as possible. And now we can appreciate the S mark, so we know that the graft is right side up. Now with a few shuffling bumps, we try to get it in position and then to unfold it in position. This is key in DMEK, to not unfold the graft in the angle, because if you do, it'll get stuck there and you'll probably need to resort to direct manipulation, meaning pulling the graft with a coaxial forceps. So we've injected an air bubble underneath the graft, and now we're trying to use the maintainer to pull the graft to 12 o'clock, but maybe you're not sure if you caught that, but the graft started to flip because the AC was so very deep. In this case, we could have used a larger graft, like 10 millimeters, but we don't have access to tree fines that are that big, and sometimes even the donor doesn't allow you to punch to 10 millimeters. So now we've used the irrigation cannula in the left hand and the direct manipulation forceps in the right, and we're not very happy with the way that the graft folded, and we're starting to lose graft orientation and even our perception of how the graft is positioned. So we want to do something to improve our view, and that is de-epithelializing part of the cornea. Now we've injected an air bubble again, and we're using aqueous currents to unfold the edges that we ourselves have created in the process of dragging the graft upwards to 12 o'clock. But at this point in surgery, we're not very convinced that we can improve our view any further, and as time moves on, the stain phase. We're about 30 minutes in during the unfolding process, and if we don't get proper positioning and unfolding at this time, the view is only going to get worse because of the edema and because of the loss of the trypan blue. So at this point in surgery, we see that there's an S mark that's properly positioned. We see no folds, so we take the win and we inject the final air fill. This patient was rebubbled the next day, and he's doing fine now at 3 weeks after the surgery. Thanks for watching.